Okay, we've officially begun. Hello, everybody. Today is Therapy Thursday. It is November 17th, 2022. My name is Evan Adler. I'm a physical therapist here at UNC Therapy Services, and I am the creator, curator, host, and sometimes presenter for this Therapy Thursday, brought to you by UNC Therapy Services and the Community Engagement Committee. Over the past couple of years, since COVID has come upon us, we have branched out our outreach to the community by providing these online talks in addition to our in-person outreach. So what we have here is we have a couple of things. First of all, we have a YouTube page, YouTube channel. We encourage you to go there. You might actually be watching this on YouTube right now as it is being recorded. So please do like and subscribe our page, our channel. This way you can see all of the other wonderful videos we have to offer. And please do go to our Facebook page for UNC Therapy Services, where you'll find out more information about Therapy Thursday and other events that we have coming up in person and virtually. Okay, so that brings us to today. It is, so here we are in November. This is going to be our last Therapy Thursday of the year. And this is going to be a topic that can be a little bit little touchy, a little sensitive to talk about, and possibly a little bit embarrassing, but something that is also so very common to so many of us. And many people are not aware that it's something that can be addressed with the proper physical therapy. So with that, I'm going to go ahead and turn the floor over to Beth, who has a wonderful presentation set up for us today. Beth, go ahead and take it away.
All right, thank you. And apologies for getting a late start, having technology issues. So this is on constipation, and in particular, constipation and pain, because it is a topic that affects those of us who treat outside of pelvic health, as well as just those of us as humans. How do I advance it? Sorry, more technology. Okay, just a little bit about myself. I have been with UNC almost a year now. Background is pelvic health as well as orthopedics, certified mechanical diagnostic therapist, so McKinsey, pregnancy, postpartum exercise specialist, so that's the PCES that you see in my name or after my name, and you can read the rest of it. I have 3 kiddos. I'm married. And I'm working out of the Durham Clinic, so the Durham Pelvic Health and Lymphedema Specialty Clinic. Okay. All right, so who gets constipated? Lots of us. It's something that probably we've all experienced, we've all been through. It's no fun. It does affect 4 million Americans. And that's not just 4 million Americans that have ever had it, but 4 million that frequently get constipated. It adds up to a lot of money. It adds up to a lot of physician visits. It affects a lot of us, but it does often affect women, particularly those who are 65 and older. It is very common in pregnant women for a variety of reasons, and it is also pretty common in those of us who have had surgery, so in the time following that, as well as with childbirth. And so, again, those are going to be populations that a lot of us see. What is constipation? I think we all have a sense of what it is, so this goes in more to how do you officially get diagnosed. And so you would have 2 of the following characteristics for at least 12 weeks, but they don't have to be consecutive. So straining during a bowel movement, lumpy or hard stool, a sense that you're not fully emptying your stool, a sense that you have a blockage either at the end of the system, so at the anus, or even higher up, and then fewer than 3 bowel movements a week. So we're all a little bit different, but 2 of those is what is considered constipation. And the poop chart. I always think this is a neat thing, and it's always good for a laugh in clinic. But this is how we can talk about poop and make it more accessible. So it's hard to describe your poop, and that's where folks get a little bit nervous, but the chart helps. So 1s and 2s are not generally what we want. 3s and 4s are generally what we do want. And then we've all been down to the 6s and the 7s, so we want to live in the middle. Oops, that one repeated. So other signs and symptoms of constipation, and this can be something that you can look for in the clinic generally, and of course, these signs and symptoms are not unique to constipation, and so it's more of a constellation of symptoms that you're looking for. So bloating, again, not feeling like you're able to fully empty your bowels. Headache can be a sign, bad breath, decreased appetite, skin eruptions, or think acne, flatulence, depression, impaired quality of life, and not on this list, but I often find folks complain of nausea. Different diagnoses that can cause constipation, again, for a variety of reasons: MS, Parkinson's, chronic idiopathic intestinal obstruction. That's a rarity, not rare in diagnosis, but rare that we're going to associate with that. Stroke, spinal cord injuries, then the different metabolic and endocrine disorders, diabetes, uremia, hypothyroidism, hypercalcemia, poor glycemic control, so even outside of diabetes, and then celiac disease, and then those who are not celiac but still gluten sensitive or intolerant. And again, just more disorders that can cause constipation: amyloidosis, lupus, scleroderma, IBS, and then just an idiopathic intestinal issue. And then down lower in the chain, intestinal obstruction, scar tissue, so start thinking that way: surgeries or endometriosis, so surgeries to the abdomen, diverticulosis, Hirschsprung's disease, tumors, colorectal strictures, cancers. These are all things that are squeezing, narrowing, again, at the end, so narrowing the intestine, the rectum. This is always something that I kind of go over when I'm doing a chart review, but medications that can cause and contribute to constipation. So pain medications. So that was something when I was doing strictly orthopedics that we ran into. So the narcotics post-operatively with the surgical patients, they're on pain meds, and some pain meds cause constipation. Antacids that contain aluminum and calcium, different blood pressure medications, specifically the calcium channel blockers, anti-Parkinson's drugs, antispasmodics, antidepressants, iron supplements. So think about your patients that are anemic, diuretics, and anticonvulsants. And also to add to this list, it doesn't always affect, but antihistamines can also cause some dryness and a tendency towards constipation. When your hormones are fluctuating or when you're struggling with your hormones, constipation is more common in menopause. And menopause is that time in life where we do see hormone changes. Menopause, we see a drop in estrogen and progesterone. When your estrogen goes down, cortisol tends to rise. This can slow down the digestion. Too little progesterone can cause your colon to slow down. A drop in either or both, and the stool tends to get drier. A drier stool leads to constipation, or it can. And then also keep in mind those who might be taking prescription medications or, so taking prescription medications rather than just having a natural fluctuation. So then if we go past the diagnoses and we just look at your average causes of constipation that we might all experience outside of diagnoses, not enough fiber in your diet, lack of physical activity. So think about your elderly or even those who are decreasing their activity maybe post-operatively. Different medications like we looked at before. Milk can do it for some of us, although milk causes diarrhea in others. Irritable bowel syndrome, changes in your life or routine, such as pregnancy, aging, travel, surgery, or injury, abuse of laxatives. So the irony there is we might take a laxative because we're constipated, but if we get reliant on them, then that can lead to more constipation. Ignoring the urge to have a bowel movement. So think about your risk populations. This might look like perhaps people that drive for a living, maybe your teachers or your nurses that have to delay because of occupational demands, and then being dehydrated, and then like we looked at prior to specific diseases or conditions that can contribute. Things that you might hear or things that you might see in the clinic, abdominal bloating, possible pain posture where they're flexed in the trunk and they're muscle guarding. So think that might also look a little bit like a low back patient, right? Someone that has pain in their lumbar spine. Poor pelvic muscle awareness. So they don't really know what's going on. They may tighten up when they mean to relax. They may relax when they mean to tighten up. Decreased gut sounds, difficulty bearing down, that kind of relates and goes back to poor pelvic muscle awareness. Tense or tender in the anorectal area, so they might describe pain with sitting, they might describe it's uncomfortable to sit, they may prefer not wearing certain types of clothing, so maybe jeans, for example, and then perhaps not something you would see in the clinic, but poor toileting habits. Their ability to get their waste products out is not so good. Going into just a little bit of studies, didn't want to dive too deep in this because, you know, it can get a little boring at times, but there is a positive association with chronic pain and constipation, and you can probably think of a great many reasons why that could be. So pain medications, altered mobility, decreased activity, the tension associated with not feeling good. And then this is especially true for low back, lower limb, and whole body pain. Constipation and the spine in particular, so the sigmoid colon lies across the sacral plexus. So if you're full of poop and you've got all of that solid material and that is laying across and putting pressure on your sacral plexus, that can cause sacral pain. And then with associated nearby structures, you might even get pain in other areas. The splenic nerves also contribute to GI function, and they begin around T5 and continue to cauda equina. So again, think about the populations that you might see that are having issues around T5 and then all the way down. So if they've got stiffness there, maybe they have a bulging disc, or maybe they've had surgery to that area, that might contribute to some GI function issues. If they are a person who is excessively straining, they could cause a bulge to one of the discs, potentially. I'm not sure what the statistics on that are as far as how often that would occur. I would imagine it's not terribly often. Pudendal neuropathy, so any sort of trauma to the buttocks or the pelvis. Diabetic neuropathy, excessive sitting on a hard surface. So think about your folks that ride bicycles, so cyclist syndrome, excessive physical exercise, poor posture, and then stress. Stress is more of a tension in the pelvic floor. Tension on the pelvic floor can create poor mobility for the nerves. And then things that your patients may say to you that can kind of be an indicator that maybe more questions are needed. Pelvic pain with sitting, but they feel better when they stand up, or they feel better when they sit on a toilet seat. They have tailbone pain in particular, and like kind of mentioned earlier, discomfort with tight clothing. So think about maybe jeans. Phantom pain in the buttocks, legs, and feet. So again, there's a lot of overlap with maybe those patients that we're seeing that have spinal complaints. So helping to kind of tease out who who might need to have a little more help beyond just looking at the spine. So constipation and chest pain. Trapped gas often occurs with constipation, which can lead to bloating and at times pain. Normally the pain is felt in the abdomen. It can be felt in the chest. Again, probably not terribly common, but it can be a thing. Chronic constipation can lead to needing to strain to eliminate, and straining is often produced with contraction of the abdomen and at times the chest wall. Surgical and pain patients. So just in general, they're not going to be moving as quickly. They're going to be a little bit slow. It can affect their ability to get to the bathroom in a timely fashion. So they might be delaying their bowel movements, and that can contribute to constipation. So they may need to adjust their habits, start their trip to the bathroom a little sooner or as soon as that urge occurs. Decreased or restricted activity, again, kind of feeds into what we just talked about. If they're painful, if they have decreased energy, if they have safety worries, so maybe they're moving a little more cautiously. They currently are, taking care of an injury, or they've got altered abilities due to their post-op state, that can contribute to pain, that can contribute to constipation. Again, just like mentioned before, narcotics and other medications that might be being used at the time can contribute and make constipation a problem. Diet changes, maybe with those medications, or maybe post-operatively, they have some changes to appetite. They might be nauseated. And so when we change our diet, our constipation might become a problem. We go through different diet changes for different reasons. If we start keto, if we are doing intermittent fasting or different options that there might be out there, it might be affecting our fiber. It may just be a change that the body's got to adjust to. So we may see a temporary presence of constipation, or it might be that we're going to have to deal with it more long-term. We're going to have to get creative. If your fluid intake goes down, you might be nauseated. You might be using fluid, reducing your fluid to try to reduce your trips to the bathroom. Maybe it hurts to get up and go, so maybe you don't drink as much. And then that in and of itself can contribute to constipation. We like to see folks get into good positions to have a good bowel movement. So often a lot of us have heard of squatty potty, so getting into a squat position to help with the bowel movements. But if your hip hurts, that's difficult to do. If you're, maybe you've just had knee surgery and that's hard to do. So different areas of pain or different areas of strength can affect your effective positions. Any change in routine, the GI system can be a little bit of a toddler. It doesn't like changes. Having your sleep patterns affected, so maybe due to stress, maybe due to something that hurts, so when you sleep you get woken up due to pain, or any variety of reasons. And then just a change in people and places. Some of us are bathroom shy. We only want to poop at our house. Or maybe we don't like to poop, I don't know, all the different reasons. And so you can imagine maybe if you've had surgery or you have a new diagnosis, maybe there's new people in your house, maybe there are different places you're having to go. So the timing that you normally have is a little bit different, and that can affect your ability to have bowel movement. Some practical tips for relieving constipation. Some studies have shown us that generally just aerobic exercise can help us. We get some good blood flow going, we get some good movement, and that can help with a variety of things, including bowel movement and decreasing constipation. Teaching good abdominal awareness for intra-abdominal pressure for the bowel movement. And so what I mean by that is we bear down, and that is a change in intra-abdominal pressure, and just becoming aware of how to use that to our advantage activation of large muscle groups, and the trunk is weak, so the legs and the trunk. So just having better strength there can contribute to our ability to have bowel movement and then reduce constipation. Activities that promote lengthening where needed, such as the pelvic floor and abdomen, so lengthening or relaxation. If we're overly tense and we can't let those muscles go, it's hard to have a bowel movement. And so then that kind of leads into just general relaxation is a great goal for exercise to help us. Yoga can also be a way to help us reduce constipation. So it's breathing, it's movement. It can be associated with relaxation. We're getting some blood flow going. And then there's some psychological benefits to yoga, and that can help with some of those signs and symptoms associated with constipation. Dietary changes that can help. So fruits that are higher in sorbitol. It's just a naturally occurring chemical that is higher in some fruits, so apples and apricots and blackberries, cherries, nectarines, peaches, plums, and prunes. Also avocado. I can't remember if it's a fruit. But sorbitol draws water to the colon, and that can help with preventing the drier, harder stools and help you pass your bowel movements a little easier. Increasing your fiber, so particularly insoluble fiber. And so I always tell my patients that soluble fiber is the stuff that if you leave it in water overnight, it's going to swell up and absorb a lot of that water. And if it's something you leave it in water overnight and when you wake up in the morning, it's still just wet whatever. So think kale and corn. It's just wet kale or wet corn. That's your insoluble fiber versus soluble fiber, think maybe rice or oats or something like that. And again, remember the GI system is a little bit of a toddler and it doesn't like quick changes. So you have to go slow. You can't fix your problem tomorrow and expect to feel like you're doing a great job. You might not feel so good. You want to eat often. So about every 3 hours, it stimulates a reflex that helps the GI system move things along. And then drinking a hot beverage upon waking can help to move the system. And then you could even do it again, maybe at a later meal dinner. Exercises, bringing one knee to your chest. So one knee to the chest, you hold and you breathe. And ideally, you want to do that good diaphragmatic breath where you're seeing and feeling the ribs move out. Before you change your legs, you could try to maybe lift the head. So again, a little bit of this is compression at the area where we move our system, so our GI system, and a little bit of it is blood flow. Child's pose. So this is a common yoga position. And what that looks like is you're on your hands and knees and you rock back to sit on your heels. Your knees might be closer together, they might be wider apart, and then letting your upper body relax down and forward. So it's kind of like a squat, you just happen to be face down. A spinal twist, you're lying on your back, your arms are out to the side, you bring a knee up and you let that knee kind of fall across the side of the body. So you're rotating the middle, you're twisting the middle to just generate some movement. And then, of course, some of us need to change up what we're doing. Some of those exercises might not be appropriate. So if you are a person or you're treating someone with osteoporosis, you would probably want to get some input on that before you gave these exercises a try. So diaphragmatic breathing and constipation. So if I'm frustrated or I'm under stress or maybe I'm struggling with my breathing for different reasons, maybe asthma, I might breathe up. So that's not a bad breath, and we do it, and it's okay, but it's not the breath that we want to do on a consistent basis. We want to do the breathing that comes out. So always think about it's more like an umbrella opening, so we want to see those ribs move out. So as we do that kind of breathing, it helps our pelvic floor to relax because the pelvic floor and the diaphragm work together. As the diaphragm contracts and moves down to help those lungs fill up, all of that inside stuff, it has to go somewhere, And part of that somewhere is the pelvic floor elongating and relaxing. As we do that good diaphragmatic breath, it also stimulates our vagus nerve. When we stimulate vagus, we're in a more relaxed state, or hopefully we are. And that then can relax pelvic floor muscles, and that then can help us with having a bowel movement. The relationship between the diaphragm and the thoracic spine produces movement there. And when we move better in our spine and our low spine and our middle spine, that can improve our function. We want to make sure we're doing good slow breaths. We don't want the quick breaths. We want to do those nice slow breaths where our ribs are coming out. We want to see our belly kind of rise or get bigger as we inhale, and we want to see it lower or get a little bit smaller as we exhale, because our bellies will move a little bit with good breathing. We don't want to breathe too much up towards the head, just like we talked about, so not too much up. It's a good thing to do at times, or sometimes it's a little bit stress relieving or it's necessary, but it shouldn't be the thing that we do all the time. Squatty potty, super fun to talk about. It is just a way to position yourself so you're more in a squat position. You can substitute a squatty potty, the brand name. There are lots of other brands out there. You can use a box. You can use the step stool that maybe your toddler is using to dry their hands or to reach the sink. Anything that gets those knees above the hips. And how far above the hips? Well, that's just going to depend on each individual. Some of us need a little bit more. Some of us need a little bit less. We do want to have our feet nice and flat and relatively wide. This is more for those of us that are treating patients, those of us that are therapists, but you could also use this as like a little personal check to see if you might benefit from Pelvic Health Physical Therapy. It's just a quick little questionnaire. And if you can answer yes to 3 or more of these, you're probably a good candidate to see a pelvic health therapist. This can be nice just to kind of check yourself, or again, if you're treating, you're a pelvic or you're a physical therapist, sometimes this is a nice questionnaire because it's easy to fill out, it's easy to read. It's questions that we all have experience with, and so we're all really sure of those answers. And it's a touchy subject, so sometimes we don't want to chat about it. And so the questionnaire is a nice way to get some of that information across. Yeah, that's it. So there's my contact information. And does anybody have questions?
Beth, thank you so much. That was that was really great, really interesting. I know as a physical therapist specializing in orthopedics, we don't get many patients that come in the door specifically looking to treat constipation or pain related to it, but it is something that we kind of look for when there's pain in the abdominal area, low back pain. That's something that is a consideration.
Right.
And I would like to say that, we do have patients when they come in for orthopedics, where it's not just the constipation, but there are lots of gas pains that are involved, abdominal gas, abdominal, bloating or whatnot. We have many patients that when put into certain positions to help relieve all that, there can be some flatulation in the clinic, and hey, it happens. So not something to worry about when you're in the clinic with us. So with that said, I did not see anybody have any questions put into the chat, but if you do have questions, now would be the time to drop them in there. I'm going to go ahead. I'm going to put that those couple of links back into the chat as well, so you can see them in the chat there for the YouTube link and the Facebook link there. Before we close this out, I'm going to leave Beth's information up there for a moment, so you can take down her information in case you have any questions there. It looks like someone's raising their hand here. let's see. Uh, Jeff, if you want to unmute and ask a question, that
Hi.
would be fine.
Yeah, my name's Jeff, and I am a patient, and dealing with so many of the kind of complicated medical conditions that you mentioned, as well as quite a heavy set of medications. I just talked with my doctor yesterday because of this exact issue, constipation. He said I needed to reduce some of my meds, including the pain meds, depression meds, everything that has been sustaining me for the last 15 to 20 years. And I said, great. And I walked out of his office and I realized he gave me no plan. There was no plan of how to try titrate down. How do you find a doctor or somebody to oversee that kind of process? It's easy to say, get off those meds. It's a whole other thing if you're a patient and have to do it.
Right. So as far as reducing the meds and coming down off it, it's definitely a little bit different depending on all the different things you're on, right? So some of our meds we really do need to kind of back down slowly, and that's something that needs to be done with a physician. So some of our drugs, particularly maybe for depression, some of those we don't do so well when we come off of them too quickly. And so very often I think that needs to be the person that is prescribing them to help you with that. Some of our medications, the ones that are as needed, those are a little bit easier to maybe make individual decisions and taper down. But even those, if you are being managed with your maybe chronic pain and that's why you're on those, again, that's a really good conversation to have with the providers that prescribe so that you have a game plan together. And I do think that very often it ends up being the provider that prescribes that needs to be involved in doing that. I don't know that there's often going to be one provider that really wants to handle it all. Perhaps a general care physician might feel comfortable with that, with a little bit of consulting here and there, but that might be a great place to start. But that can be tricky, and it's kind of frustrating when you feel like you've gotten to a baseline with management of your symptoms, and then you figure out that you're having trouble with something like constipation. And of course, I'm a pelvic health PT, so I'm always an advocate of pelvic health PT. I think that can be a great place to go and to start with other strategies. And so not just relying on one thought pattern of just reducing the meds. So I think we do great work, and I think we often have a lot to offer that that is different than maybe just your medical provider, your medical physician. Does that help?
That helps usually. The only comment that I would say is that the internist who prescribes most of these medications is the one who reinforces at each meeting that these medications are necessary. So the person that is, prescribing those medications is not necessarily the person who's going to want to take you off of them, because that person has you on them because they think you need to be on them.
Right. That's definitely a tough position to be in if you're getting different messages from providers. And that, sometimes you can go back and have really specific conversations, or sometimes your providers can speak to each other to help with a game plan. But it's definitely not a fun position to be in when you feel like you don't really know what you should do first. But yeah, maybe have a conversation with your internist that feels like it's a good combination, and see if you can talk together about the concerns and the instructions from your other provider.
Thank you. Huge help.
Sure. Thank you.
All right. Thank you for that great question. Thank you, Beth, very much for your presentation here today. I want to thank everybody for joining us, and do go to our Facebook page where you'll find more information about the next Therapy Thursdays, which will be coming in the new year. We're going to take December off. So thank you all so much. Have a wonderful rest of your day. Have a fantastic holiday season, and we will see you next time. Thank you.